this afternoon. Wherever you are, I'm glad to welcome you all at this session, which is about radiotherapy for pediatric medulloblastoma. So I welcome you all on behalf of the SOST Working Group of SIOP Global Health Network, Pediatric Radiation Oncology Society, and West Germany Proton Center in Essen. So during this session, Professor Kortmann would talk about radiotherapy for medulloblastoma, and towards the end, we will have question and answer, and Dr. Janet Parks from South Africa and Dr. Joki from Nairobi, Kenya would be coordinating that part of the session today. So during the talk, you can write your question and answer in the chat box. I would like to invite Professor Beate Zimmermann from West Germany Proton Center in Essen to introduce our distinguished speaker today.
Yes, thank you, Bilal. Yeah, it's a real pleasure that we can meet today to discuss radiotherapy in medulloblastomas. It's really important that we meet from all over the world to discuss those rare diseases. And I was very happy that Professor Rolf-Dieter Kortmann accepted our invitation to share his experiences here. He's a highly reputed expert in pediatric brain tumors internationally, and I think he's the best one to introduce us to the medulloblastoma and radiotherapy. So, Rolf, please go ahead to present your talk.
Yeah, thank you very much, Beate and Bilal, for the introduction. Yes, to compress the knowledge about medulloblastoma in 40 minutes, it's not an easy task, because over the last 50 years, since when the first studies started in Europe and America, a lot of knowledge has accumulated. So first, I would like to give a very short overview what we are talking about. It's a rare tumor, but among the CNS tumors, it's the second most frequent after low-grade glioma and comprises 20% of tumors. Midline location, incidence, as I told, very rare, and is approximately 29% of childhood cancer. Survival for all stages is around 65%, and everybody is working on an improvement. And if a high level of improvement is achieved, we are currently working on reducing the toxicity and intensity of treatment. And a very important question for us radiation therapists is the propensity for leptomeningeal spread requiring craniospinal irradiation. And a lot of patients have evidence of leptomeningeal spread at diagnosis. Extra CNS is rare, and most of all, it is a radiosensitive tumor and also chemosensitive tumor. But the long-term toxicity is problematic, in particular for infants. So the clinical features, as with all posterior fossa tumors, raised intracranial pressure due to the obstruction of the fourth ventricle, visual disturbances, ataxia and hemiparesis, dizziness, neck pain. For diagnosis, imaging is essential before going into treatment, which is normally upfront surgery. A CSF cytology should be performed 14 days after surgery, imaging preoperatively, brain and spinal canal, and shortly after surgery. And it should be done around 24 to 74 hours. And postoperative cranial MRI to assess possible remnant disease. There is a tendency of metastatic spread, which is labeled as M1, M0, M1, M2, M0, depending on the sites of meningeal spread. Now, let's come to histology. The classical histological features included the most frequent one, which was the classical medulloblastoma. In the younger cohorts, we also observed a more benign cause, the desmoplastic nodular medulloblastoma, or those ones with extensive nodular expression. And there's one histological type with a poor prognosis, the aggressive tumors. These are the large cell anaplastic medulloblastomas. Today now, these tumors are now subqualified according to their molecular genetic profiles, and this is permitting a more deeper insight how the, let's say, the aggressivity of tumor can be estimated and assessed. And essentially, the classical criteria risk profiles were depending on the extent of disease, whether metastatic or not, and the age of the treatment, diagnosis and treatment. And in the younger ones, normally we are not giving radiation therapy, only in very few cases, whereas radiotherapy has become standard in the more in the older age group. And as you can see here, these can be subdivided according to these molecular genetic profiles, the sonic hedgehog and the non-sonic hedgehog, whether they're TP53 mutations or not, and they're normally treated with chemotherapy. I do not address these cohort of patients in my talk. I rather focus now on those patients carrying a specific risk profile that has been defined by their molecular genetic features. And as you can see here down, we have a comparatively standard and uniform dose for the non-metastatic patients with craniospinal radiation, 23.4 gray. And for those ones which are markedly higher aggressive among these non-metastatic tumors, especially the anaplastic tumors, they need a higher dose prescription. So what trials have been performed over the last years? Not the very old ones, the original ones from the 70s and 80s, but I'm rather focusing on the more recent ones starting from 2000. So this is just a extraction of these studies for M0 patients. And as you can see here, it has been investigated whether the addition of chemotherapy is contributing to a better outcome. And in this trial, it could be seen that the addition of chemotherapy was improving the 5-year event-free survival. Another trial, the HIT 91 trial, investigated upfront chemotherapy followed by standard radiotherapy with 35.2 gray, as compared with chemotherapy after radiotherapy. The maintenance chemotherapy is the so-called PACA regimen. And as you can see here, this upfront radiotherapy, chemotherapy approach, covering almost 4 to 5 months before starting radiotherapy, showed an inferior outcome, but a better outcome in the metastatic diseases. And there were some alternatives, giving no chemotherapy with a high-dose prescription, giving hyperfractionation. There were 2 trials showing a good outcome. And this has been investigated in a trial run by the SARB in the early 2000s. And in this concept, in this study, this randomized study, no superiority of hyperfractionation has been found. But what did we see? So we saw that the molecular genetic profiles from this study and the past study has showed that if they have a specific profile, they have a very good outcome. And this was mainly determined of the absence of anaplastic features, but the presence of beta-catenin and the absence of NMYC amplifications. So that means these might be liable to a de-intensification of either radiotherapy or chemotherapy. And those with a poor outcome, they apparently need a more intensified treatment. So this led to the PNAT4 trial investigating 18 gray dose reduction in WNT tumors, and a conventional dose prescription, but with simultaneous carboplatin in the standard risk cohort. And in both arms, we restricted the target volume to the boost from the posterior fossa down to the to the tumor bed, which has been investigated in the ACNS 0331 study that has been published by Jeff Michalski. They compared 18 gray with 23.4 gray. It was a big study. And here in this study, it could be demonstrated that the dose restriction is risky. It cannot be afforded to all patient cohorts, which we have investigated in the ongoing PNET5 trial. The results are not available, but so far in the low risk arm, not an increased risk for failure was observed. And in a sub-analysis, Jeff has seen that this possible dose reduction is not feasible in the so-called group 4 molecular genetic subgroup. So I would like to focus only on one trial, which was an American one, in which these risk categories have been investigated in more detail. We know this from the past, many stemming from the old European data. And in this study, the good prognosis of VNT tumors has been seen. And additionally, in this study, patients with high risk features, which means metastatic disease, were also included. They received a higher dose, namely 39.6 gray. And again, this subgroup profile initially also has shown that these prognoses can be different and is depending on the expression of these markers, whether they are sonic hedgehog positive or they are VNT. Just have a look at this very poor outcome. Later on, I will resume that in another trial. So this was a particular study softening the strict risk profile difference between metastatic and non-metastatic disease, because we have a certain overlap. We have high-risk features in non-metastatic, and we also have low-risk features in the metastatic ones. And in the low-risk medulloblastoma, so far assessed by molecular genetics, now further dose reductions are now under investigation down to 15 gray in one study and St. Jude. This is the St. Jude MB12 protocol. And this will be pursued in the upcoming PNET6 trial, which is currently in development. So how was the high-risk profile? We know this from the HIT91 trial, that those ones with metastatic disease have a much poorer outcome. And this shows an example how the scenario in these high-risk metastatic patients are. And I've highlighted with red all those studies that have introduced a more intensive radiotherapy approach beyond the standard of 36 gray. So this was one American one with 39.6 gray. This was the so-called hard hyperfractionated accelerated combined with intensive chemotherapy with a very excellent outcome, 5-year PFS of 72%. Or, which is more or less a competitive protocol, to give concomitant carboplatin to radiotherapy in metastatic ones, showing a good outcome. Or conventionally fractionated 40 gray with 1.6 single gray dose, good outcome. Roger Taylor investigated this hard approach in a smaller cohort and also showed a good outcome. We have investigated hyperfractionation with a higher dose, including a more intensive chemotherapy approach, very good outcome. And a concomitant high dose concept also with VP16 concomitant to radiotherapy. But the best results so far have been obtained by the Milan protocol. But this has got to be observed with caution, because if not handled properly, in particular with respect to high-dose chemotherapy with stem cell transplantation after treatment, it might show a high toxicity. So we've also seen in our HIT 2000 study the prognostic impact of the molecular genetic profile on outcome. And as you can see here, even in metastatic disease, the VNT tumors have an excellent prognosis. And now they've been taken out of the high-risk profile, although they were metastatic, and treated within the concepts of the standard risk profiles. So these are the results of the heart study of Milan. So exceptionally good outcome. And at longer follow-up, the outcome, even for the poor seen in the United States in the ICNS protocol, sonic hedgehog tumors, is apparently better. But this needs to be proven in subsequent trials, such as the now ongoing high-risk medulloblastoma of the SIOP. So carboplatin. Carboplatin, simultaneous to radiotherapy, is apparently not efficient in general, apparently only in the group 3 tumors. And in this cohort, it is giving a very good outcome. So what is SIOP investigating? SIOP is investigating the heart concept and comparing it with 36 gray craniospinal axis as standard treatment. And this is a very, let's say, elaborate study, including comprehensive biological studies, which I think, and this is a general acceptance now, how to approach these tumors. The biological and prognostic biomarkers permitting a stratification of treatment, both for radiotherapy and systemic treatments. So, RT in infants. I wouldn't address them straight on, but as radiotherapy is indispensable, salvage radiotherapy is a very important component. And this study, for instance, has been discontinued because in which no radiotherapy was given because of the high relapse rate. But as you can see here, the difference between the progression-free survival and the overall survival is high, which means that salvage radiation therapy in this prognostic, very, in general, favorable subgroup is giving a high cure rate, albeit to the expense of relapsers, which means that the relapse treatment is an effective treatment in the very young. Whether in the long run this is superior in the functional outcome is still an open question. And this was a very large cohort covering European and US American children, clearly showing the efficacy after relapse. And concerning the dose prescription, it is not quite clear yet which dose is necessary to give at which circumstances. Apparently, those patients that are relapsing need a higher dose, but you have and those who are relapsing locally, they need apparently not the higher dose, which is necessary for metastatic diseases. So these 23.4 gray that has been normally given might be sufficient in these patients not showing a systemic, but only a local relapse. So what is the option when treatment has failed after craniospinal irradiation? The repeat radiation is an important tool. And apparently, as you can see in this study from Boston, in which second radiotherapy has been given in a recurrent disease. And there are no prospective trials available in which second course radiotherapy after craniospinal irradiation is systematically investigated. But interestingly, in one study, the 3-year survival after repeat craniospinal irradiation is 50%. After local, it's only 0%, which opens up the question now how and when to give repeat craniospinal irradiation, in particularly those patients undergoing a lower dose prescription, and focusing the tumor bed boost, radiotherapy to the tumor site only, because this is essentially permitting a more aggressive radiotherapy approach than was currently as compared with the past restricted possibilities after 36 gray craniospinal irradiation and boosting the entire posterior fossa, including the brainstem, up to 55. So this was a very important study showing us that craniospinal irradiation is indispensable. So this is now 32 years ago, but clearly indicates craniospinal irradiation cannot be replaced by chemotherapy. And these recurrences, interestingly, were mainly supratentorial. So in this study, only the spinal canal and the posterior fossa was given. Now with the modern treatment technologies, we are increasingly using proton therapy, but at least, let's see, VMAT technologies or tomotherapy to tailor radiation therapy to the target volume. So this was an analysis of different treatment technologies, IMRT, VMAT, tomo, proton beam therapy. And the conclusions were, let's say, a little bit restrictive. But on closer look, you can see that in particular, the non-target dose distribution after proton therapy, which means lung, the esophagus, the heart, could best be preserved by proton therapy. But I will come to that later concerning the possible advantages of proton therapy. The target volume definition. Craniospinal axis irradiation is a complex technology that requires experience and skills. And we made a lot of experiences in the, let's say, the homogeneity in target volume definitions among the participants in our AstroPros teaching courses we have offered since 2009 in 2 years intervals. So the SIOP brain tumor group radiotherapy group defined after a consensus meeting criteria how to delineate the target volumes in craniospinal irradiation. And this has been published by Tankama Ajit Kumba in 2018, also including the, let's say, the nerve roots, in particular, the cranial nerve roots, and the reliability of contouring the craniospinal axis space. Additionally, we have also looked at, in this group, at the possible growth problems in patients undergoing craniospinal irradiation away from contouring the CNS components. So we've seen that it is important to consider dose gradients within the vertebra to avoid growth disturbances. The AstroPros teaching course. So what were our experiences? You can see that here the targeting of the target volume definition of the CSF space was considerably varying among the participants. So sometimes, as you can see here, the sinus have been included, or the cribriform plate has been completely excluded. So now the change in the target volume definition of the tumor bed boost, respectively the posterior fossa boost. So if we are going to reduce the volume, the major goal is to reduce the dose exposure in the supratentorial region, but also in the cochlea. So this has been investigated in the ACNS trial. This was the second part of the question that I have initially shown. And the tumor control is excellent. There's no difference. So in the non-metastatic patients, the tumor bed is sufficient to treat. But now it comes down to the homogeneity and target volume definition of the tumor bed. So this was another experience we made in our AstroPros teaching course. There's a great variability where and what to contour when it comes down to the definition of the posterior of the tumor bed boost. So what is presently recommended? The standard now has become 1 centimeter. But recent protocols have now introduced 0.5 centimeters. There's no firm decision yet how this, no clinical experiences yet, whether this is not associated with an increased risk. But with the regular introduction of MRI imaging in co-registration when defining the target volumes, I think 5 millimeters should be a sufficient safety margin. But if you are going to contour a tumor, I can only recommend to perform this restriction only in treatment protocols in order to assess whether this is really a way without risking increased relapses. So why reducing the volumes? Apparently this has an impact on the dose distribution to non-target tissue, in particular the hippocampus and temporal lobes, which are important for the neurocognitive function. And there is a dose-response relationship. And on this slide, you can see that, let's say, beyond 1820 gray, the neurocognitive function declines. So on one hand, we have, let's say, the flat dose given by craniospinal irradiation. Let's not talk about hippocampus sparing at the moment. And the possible impact on the IQ score. And now, if you are giving the reduced dose plus posterior fossa and compare it with the standard dose, you see apparently no difference, which means there's no difference between 36 and 23.4 gray, unless you are giving a tumor bed boost in reduced ones. If you don't reduce the target volume by tumor bed, this dose reduction does not meet its goal that you are preserving the neurocognitive function. So only the reduced dose tumor bed is giving an advantage, not with the posterior fossa. So in treatment planning, the preservation of the hippocampus is important. Now back to the protons, because the protons are better able to tailor radiation therapy, in particular to the tumor side. It can be better preserve the dose exposure outside the posterior fossa. And in these two studies, the neurocognitive function has been compared between photons and protons. And the full-scale IQ and the global intelligence is in the proton group, significantly better as compared with the conformal IMRT approach. So how reliable is target volume definition? So in our studies, we have performed a upfront quality control program, and ever so often we could see that in this study the target volume contouring was not performed according to the definitions in the protocol. And we've seen for both dose homogeneity and the correct definition of GTV, CTV, a high percentage of unacceptable deviations. But it's not as worst in the long run, because we have seen a learning curve. The more patients were treated in one institution, the better, and the target volumes have been defined. I didn't show you the past slide in which it has been shown that the quality of radiation therapy and the precise application of radiotherapy is indispensable for a good outcome. So this is an example in proton therapy. This is craniospinal axis irradiation in a 9-year-old. And you can see here with 23.4 gray, the entire vertebral body has been included to avoid growth disturbances. So with 23.4 gray, no dose gradient within the bone is necessary. But I do not have a treatment plan with tomotherapy, for instance, or VMIT at hand at the moment. But you could imagine that with protons, it is much easier to introduce this dose gradient within the spine, and at the same time sparing the non-target tissue, which means the pancreas, heart, lungs, etc. And these organs are excellently preserved with proton therapy. So now as to the dose volume histograms. With protons, you can excellently spare lungs and kidneys. So I didn't show you the results for heart, esophagus, but for all these organs at risk, the dose exposure was in craniospinal irradiation was below 1 gray, which means in particular for the heart, this is out of the risk dose prescriptions we know from breast cancer cohorts, without risking cardiovascular diseases. And we also, with the boost, we could excellently spare the hippocampus and the hypothalamus region and the cochlea. So, in summary, radiotherapy of the craniospinal axis boost is indispensable. The exception is the children younger than 4 to 5 years with low risk profile, and radiation therapy is often offered as salvage therapy. So for patients with non-metastatic disease, 23.4 gray appears to be possible, but not in every molecular genetic profile defined subgroup. We are now in the area of new classification of risk groups according to conventional histology and molecular markers. So for low-risk patients, now a dose reduction in radiotherapy is investigated, the reduction of chemotherapies as well, and the boost to the tumor bed will be continued with a smaller target volume. So for intermediate standard risk, the role of simultaneous carboplatin and boost of tumor bed is investigated. And for high risk, a more intensive radiotherapy approach and the role of simultaneous carboplatin. So the tumor bed will be reduced now down to 0.5 centimeter, but within clinical trials. And the proton therapy have an advantage in dose reduction to non-target tissue within and outside the CNS. And we know that second RT in recurrent disease is possible. And the role of craniospinal axis is, however, at the moment not sufficiently assessed yet. The neurocognitive function, we know several factors that are age, the integral dose to temporal lobe and hippocampus. And I think the quality assurance is very important within these studies. And for the treatment outside studies for craniospinal irradiation, I think training programs and, let's say, webinars like this are very helpful. So now I'm open for discussion, and I thank you very much for your attention.
Thank you so much, Prof. Kortmann. And I think all 167 participants that are online are basically asking some of the questions. So we'll start going through them. Radwa Sabra, I'm not sure where she's from. She asks, is it safe to irradiate the tumor bed in high-risk M0 patients?
In high-risk M0, good question. At the moment, it is difficult. I think I can only recommend it within trials.
Okay.
I think the data are sufficient enough now to treat the tumor bed only outside a clinical trial in those patients that are falling in the, let's say, standard and low risk category with the current stratification that has been published by the SARB brain tumor group that can be downloaded from Simon Bailey. There you can see it.
Perfect. And I guess also tailoring care for some of these patients who sometimes are quite difficult to manage depending on where someone is on the globe. Perfect. And then Victoria Fernandez says, a great talk. And in case of re-radiation, what are the issues for long-term toxicity and quality of life?
Good question again. Well, as you could imagine, that we are giving cumulative doses to the brain. And the most reliable data are still those with repeat irradiation leukemia of past series, long time ago. And there is a high risk if the total cumulative dose is exceeding 40 gray, even there's a larger interval. So, those children with relapsing tumors have a very dismal prognosis. And therefore, data on long-term toxicity after repeat irradiation in these dose levels are unknown at the moment. But it can be expected that there will be late effects. So it has been discussed with the parents whether they would undergo a repeat irradiation course. We are currently recommending 19.8 gray or 20 gray in recurrent medulloblastoma after standard dose irradiation with 23.4 gray and boost to posterior to the tumor bed. I think the tumor bed boost and the cumulative doses is not an issue for neurocognitive function. It's more an issue of possible problems in the brainstem. But with respect to brainstem toxicity, we have now a lot of experiences in repeat irradiation in ependymoma in this region. So there we are on safe ground.
Okay, and I think a follow-up question to that, Prof, was, is there any timeline between from one treatment to another, especially when we're doing re-radiation? That's a question from Diego Gonzalez.
Yeah, the longer the better. Better not before 1 year, particularly with craniospinal irradiation. After 6 to 9 months, repeat irradiation ependymoma is possible, but for craniospinal irradiation, I'm more cautious.
Fair enough. Okay.
But there are no let's say, defined criteria established yet.
Or timelines. I mean, the longer it is, at minimum of maybe a year, if longer, if better, would be better.
The longer the better.
Okay. And then I think I'll try and put two questions together. Guadalupe Vega says she's from Chile, and her question is on irradiation of children under 4. Michelle also has a similar question on another 4-year-old child, low risk, who has had surgery. 11 months later came for radiotherapy, has gotten chemotherapy with etoposide, vincristine, and carboplatin, 8 cycles. And then they made a decision to give 30 gray to the craniospinal axis, not 23.4. So I think here the second question is about the gap, and that is a recurring theme in some of the low and middle income countries, from time of surgery, chemotherapy, and radiation.
Well, we know that we may not exceed 42 days from surgery to start a radiotherapy in the primary setting. For the relapsing patients, it's difficult because then, as I understood, this was a child which has received chemotherapy only as upfront treatment and then relapsed later on and then received, or then radiotherapy is planned. And in this setting, we are recommending chemotherapy before giving radiotherapy. So the interval between surgery at relapse and start of radiotherapy is somewhat, let's say, flexible, depending on the efficacy of chemotherapy. So the observation that a protraction in treatment, the protraction of the gap until start of treatment in the primary setting is only solved insofar that a short time chemotherapy might be benefit. So this was the result of the SAOP-3 trial. This was a short time, but if you are exceeding it up to 4 months in non-metastatic patients, then all of a sudden the effect is detrimental, although an ineffective treatment was given. If there is metastatic disease and relapse, it is again different. Then you can afford to give it. So it's a complex situation, and we are discussing these in tumor boards. But in general, the earlier the better.
Okay. So is there, from all the trials, is there a cutoff period with which, for primary treatment, we want to get radiotherapy in within a certain period of time?
Oh, cutoff, yeah. Well, in the protocols, we say best is within 2 to 4 weeks. So, but then it's a race against the diagnostics, in particular molecular genetic profile. And we've seen in our analysis of the 2,000 patients that a cutoff point is 6 weeks, 48 days.
Yeah.
And then the outcome is becoming worse, unless bridging chemotherapy is given. But that, I think this is not a good idea to give a bridging chemotherapy if you can start earlier.
Yeah, so the earlier you get in your radiotherapy, the better. Yeah. And then Guadalupe, I think the last part of their question was, is it safe to give radiation in children under 4 years of age? So is there an age cutoff for craniospinal radiation?
Well, this has been pragmatically decided continental-wise. And in Europe, it is even different. So in Germany, we made a cutoff of 3 years first. Then we softened it to 4 years. And some are doing 5 years. So this is let's say, a philosophy based on the working groups. There's not a biological background.
Okay.
The cutoff point is mainly defined by the risk to develop a neurocognitive dysfunction. And some say, well, if we're looking at those patients that has been investigated in the past, it was 7 years cutoff. So all those older than 7 years did not suffer from neurocognitive defects as compared with the younger ones. So it's very, very difficult to define a threshold. But as we know that craniospinal irradiation is indispensable, it should be used as early as possible. So if it is going down to the age group of 3, the chance for cure is high. And if you cannot offer, let's say, a chemotherapy approach that is sufficiently addressing the CSF space, then I think it's not a good idea not to give radiotherapy, because you need to give some very effective chemotherapy protocol. And these chemotherapy protocol discussions were going on since, well, now at least 15 years, 20 years. And there are two different philosophies. One in Europe is to give intrathecal methotrexate. And if you're not giving intrathecal methotrexate, the outcome is very poor. And other working groups are then investigating other treatment protocols, but away from these, let's say, high modern pediatric chemotherapy protocols in modern centers in LMIC environment. I think it would be better to consider early radiotherapy
rather than later. Okay.
Yeah.
And again, Prof, in keeping with the LMIC group, Endang Nuriadi asks, in the LMIC where it's difficult to get any molecular genetic profiling for medulloblastoma, if a child is M0 and standard risk, can we give craniospinal radiation with 23.4 without knowing the subtype, the molecular genetic subtype?
Yes, you can give that. Yeah, because the anaplastic features are sufficient enough. If there's an anaplastic feature in the tumor, conventional histological, that should be possible, then you should give 36 or 35.2 gray. And then the entire posterior fossa, rather than tumor bed.
Sure. And then Akil Shahid asks, what's the optimal boost dose for spinal drop meds?
For spinal drop meds, optimal boost dose.
Yeah.
Well, this is depending on the extent of the spinal cord. You can start, if there is a complete involvement with laminary leptomeningeal spread, you can give 40 gray or 39.6. And then depending on the extent of boost, this can be augmented down up to 45 gray, and if it is only circumscribed, then to 50 gray, and in the cauda region, 54 gray.
Yeah. So I guess it depends also on the location in the cord.
Yes, and extent.
Okay. And then David Asaf is from Hospital Garan in Argentina. He asks, do you consider dose constraint in the cervical cord in, I think, radiotherapy?
Dose constraint?
Second dose of radiotherapy.
Oh, second dose of radiotherapy. I wasn't clear. On second dose.
For the spinal cord?
Yeah.
Well, this is a matter of recovery and the time gap between the interval between first treatment and second treatment. And there are no specific dose constraints yet for the spinal canal. So the working groups, whether the working groups are currently addressing this issue, I don't know.
Yeah, maybe I can comment on this, Rolf. There is a European working group on recurrent medulloblastomas, and they are now starting with a project investigating radiotherapy after first craniospinal radiotherapy, also in order to evaluate dose constraints and feasibility of what was done. However, it's not easy to have all the data which will help us to model better feasibility. So in Essen, we typically do not exceed 60 gray cumulative dose for the spinal cord. But as Rolf is saying, of course, we look into recovery and interval between radiotherapy.
Thank you, Prof. Beata. And then going back to the tumor volumes, Prof, I think you had gone through this. So regarding target delineation, is it recommended to cover the optic nerves? And I think these are areas where we get a lot of recurrence, depending on the contouring of the CTV. So is it recommended to cover the optic nerves?
Well, isolated recurrence or even an involvement of the optic nerve in medulloblastoma has not been observed yet. And in the past series, the optic nerve was included whether we want it or not. But now with VMAT and proton therapy, it is possible to exclude them in order better to preserve the lenses and the eye.
Rolf, did you refer to that paper, to that guideline paper?
The guideline remains that open to the discretion of the treating institutions or the protocols.
Okay.
Just to shorten it, what Beate wanted to say. But some are doing it pragmatically. Only the third, 1/3 of the cranial nerve that is close to the brain.
Yeah. Okay. And that's because of the sleeve that you have some CSF around that same area. And then Tuba Ali is asking that you shed some light on vertebral body coverage when treating with photons in both standard risk and high risk.
Pardon me, what recovery from what?
You explain on vertebral body coverage when I think this is part of the
what coverage? What?
The vertebral
body.
The vertebral bodies. Okay, right.
When both we're treating with photons for both standard risk and high risk.
The vertebral, well, this is not an issue of high or low risk. It is the dose to the vertebra with respect to age. And this was this consensus paper that I've just shown, that the younger the child, the more important the dose gradient is. And this should be as shallow as possible. So in children younger than 6 years, it is impossible to have a gradient below 5 gray and at least 23.4 gray.
Okay.
Yeah, but this is very, very detailed in this paper.
Okay. And then there are two questions I think I'll put together. Maria, Tariq, and Mahen, sort of the same. So Mariq says she's from Aga Khan University, I guess in Pakistan, in a post-op infant medulloblastoma. She's not said what risk category, who undergoes chemo, then has complete resolution on residual subsequent imaging. Can we avoid craniospinal irradiation? And if you will incorporate craniospinal irradiation, what should be the boost volume, considering the histological group? And I think that tallies with the next question on somebody who's had a biopsy, gets chemotherapy, gets a complete response. Can we avoid craniospinal irradiation and just give a tumor bed boost?
No, I think these focal approaches, they're difficult in these children. There were some studies that have investigated that. So we have made bad experiences with focal radiotherapy only. Because we have increased rates of supratentorial relapses, like this was observed in this old SFOP French protocol. And only in the genetic TP3 mutations, there we are thinking about the local radiotherapy only because of the risk of second malignancies. But this is a very small cohort in which this can be considered. But I can only recommend not. I think it's better to give salvage complete radiotherapy than give focal radiotherapy only.
Okay. And then the other question is what strategies from Ahmed Mohammed, what strategies are in place to protect hearing in patients who are receiving concomitant cisplatin-based chemotherapy?
Well, they are dose constraints concerning the cochlea with respect to the concomitant radiotherapy with cisplatinum. And well, this can be geometrically done, but concerning any kind of substances for preservation, this is, I think, currently under investigation in some studies. There were some substances that were otoprotective, but at the same time, you have to be very careful whether this is also tumor protective. So, Beate, are you informed about any trials concerning otoprotection with some substances?
No, I'm not aware of it.
No.
Okay. And then the other question from Elena Panizo. Thanks you for a very excellent talk. She's a pediatric oncologist from Spain. The question is, currently a patient who's older than 16 with a wind medulloblastoma with multiple local remnants that are greater than 1.5 centimeters squared. Would you treat with the CSI of 23.4 or 36 and boost up to what dose?
These metastatic VNT tumors, they're interesting cases. Has this child been treated upfront with chemotherapy? It was metastatic, as I understood.
So she has not indicated whether there was chemo, whether it was metastatic. We don't know the risk category.
Well, if it is VNT and a non-metastatic, presently, well, we do not recommend 18 gray as routine now but it appears feasible, but it should not be routine. Boost of tumor bed only, that's quite sure, not entire posterior fossa. And for metastatic patients, they have a very good outcome. But so far, these metastatic VNT tumors were treated according to the high risk profiles, which means 36 gray at least. So if it is a metastatic case, regardless of the chemotherapy, then 36 gray should be given. And then it is an open question what to boost, whether the entire posterior fossa. But I would say yes, entire posterior fossa. In the high-risk medulloblastoma protocol, we are refraining from giving, let's say, the hard concept to the entire posterior fossa, but to the tumor site only. And this protocol, I didn't go into detail, has a very elaborate guideline with respect of boosting the metastatic disease with respect to remission status before giving radiotherapy.
Perfect.
So if you, let's say you have 3 brain metastases, then you have, let's see, a leptomeningeal spread, laminary metastasis, and nodular metastasis. And ever so often, you just can't give a boost beyond in excess of 40 gray for all these lesions, because this is incompatible with 45 or 54 gray. This is incompatible with the dose constraints of the entire brain or the spinal canal. Then you can only boost remnant disease rather than the original sites.
Okay.
But this is a very individualized approach. So there are no rules.
And tailor the treatment to the patient that's in
Yes.
front of you. Yeah.
Yeah.
And the other question from Radwa Sabra is there different dose to the vertebral? Is there a different dose to the vertebral bodies that may affect the vertebral growth? Which I think is what we were talking about in terms of contouring the vertebral bodies. So is there a constraint?
Yeah. Well, yes. I mean, you can look into this paper. There's an anatomic atlas and the substructures of the vertebral body and the growth plates, and concerning the definitions. It's an elaborate paper and freely available as far as I'm informed.
Thank you, Prof. I think all of us have to look at that paper, but there are constraints depending on which parts of the vertebral body
Yes.
you contour them and what you look at. So
Yeah.
I want to thank you so much for preparing for this talk, all 167 people who attended the talk. And also thank you, Professor Beata, for joining us all through. I want to hand over to Jeanette so that she can close the meeting.
Thanks, Njoki. Rolf, thank you very much for a very informative session. And to Beata and to Pros Almec for setting up these sessions. I think we can see from the attendance just how valuable and important these sessions are. So thank you very much for taking this on. And I see we've got one last question, Njoki. Lotfi is asking you, Rolf, is there any room for a stereotactic radiosurgery boost?
Not in the primary setting. In recurrent disease, yes, there are options.
Thank you. I think the other big question that came up in our workshop last week was whether or not residual tumor in the tumor bed after surgery can inform the dose of craniospinal, the risk that you confer on the patient if you don't have molecular testing. So I think this is going to be you know, in view of some of the latest publications on residual tumor not making you high risk, if you don't have molecular testing, how does that all fit together? Do you have any opinions on that?
I think the decision whether to boost is not depending on the molecular genetic markers at the moment, just at the fact that there is one.
No,
And
not the craniospinal dose.
no, no. It is a large residual tumor automatically means that there is a 36 gray approach, which is the, let's say, the high risk feature among those patients with non-metastatic disease, together with the anaplastic components.
Yeah.
Yeah, and this interesting study from Gaja and the molecular genetic profiles. So this is softening the let's say the difference or the difference between metastatic and non-metastatic, and there's an overlap. And these patients have to be treated accordingly, but this needs to be addressed in specific trials. And as long as no data are available, I think one should stay with the recommendation of the brain tumor group that this subcohort will be treated with the standard dose, which is 36 gray, falling under the category high risk without metastasis. So it's clearly defined.
Okay. Well, thank you very much. It's great to see you.
Yeah, that was my pleasure as well.
And thanks to everybody who attended. And we will see you next quarter for the next talk. So thank you very much.
Okay, thank you. Bye-bye.
Bye-bye.
Bye.
Thank you. Bye-bye.